We can start our WFNS Education Symposia number 19. We have a very interesting topic today. This is the management of metastatic spine tumors. We have a lot of changes in our practice, and the moderators will be Dr. Massimiliano Visocchi and Manas Kumar Panigrahi. I will let the moderators to continue that session. We have 1.5 hour duration, and then after that, we will start a very special conference by Dr. Robert Spester.
Yeah. Good evening. Will you start, Dr. Massimiliano, introduce something? Today we have a common topic of spinal metastasis. I request Dr. Massimiliano to tell a few points, and then we'll start the meeting. Can you hear me, Doctor?
Massimiliano, you are unmuted. You can speak.
Just to introduce this very interesting lesson, I think that there are many topics to be clarified: indication, surgical strategy, and prognosis. And according to the indication, is it always indicated to operate spine metastasis, which are the requisites and the clinical and radiological pattern to go on? And moreover, what kind of percentage of effective treatment does exist in neurosurgical armamentarium? I think that this should be the topics that we have to consider. And please, I'm looking forward and can't wait to hear our speakers. Please, my colleague.
Yeah, it's a very difficult topic because the most important is to decide to treat or not, and if you treat, whether first go for surgery or go for radiation, and if you go for surgery followed by radiation, what should be the time interval between radiation and surgery? So what we learned today is all these controversies, when to treat and how to treat, and how long to treat. With these few words, I'll request Dr. Newman to start up on speaking on decision making of a patient with spinal metastasis. Newman, can you please share your screen?
Perfect. Can you see my screen now?
Yeah, yes.
Perfect. So good morning and thanks for having me. I'm going to be touching on classification decision making in metastatic spine disease. And as you said, I'm Chris Newman. I'm from Memorial Sloan Kettering Cancer Center, and this is the majority of my practice is really dealing with this. So looking forward to this talk and really appreciate the invitation. I have no relevant disclosures. So really this talk is going to be a talk in two parts, predominantly on this first half, which is decision-making frameworks, which will really delve into how we make decisions, but also a little bit of how we classify these tumors and how we look at that. It's a global way of looking at this practice management of spinal metastatic disease, and then ending with a quick case presentation just to highlight, what this looks like in real time. And so here at Sloan Kettering, the framework that we use is the NOMS framework: N for neurologic, O for oncologic, M for mechanical with respect to stability of the spine, and S for systemic disease burden, but also how well the patient's doing. And I'll walk through each of these elements, but it's not to say that NOMS is the only decision-making framework. There is LMNOP, there is MOS, there is a alphabet soup of different ways that you can actually approach this, but it really is saying having an actual systematized way of looking at this problem is what you want. And for us, NOMS is what does that. And we appreciate the flexibility that it gives us. And so if we start looking into what gnomes is, we can start with the neurologic portion of gnomes, or the N that's there. And so the N really gets to a combination of the radiographic appearance of the actual tumor and how much is compressing the spinal cord, as well as the neurologic examination, with questions of myelopathy or radiculopathy coming into the picture when you start thinking about this. But as MRI has gotten so much better, really the radiographic correlates with the physical exam findings. And so when we think about epidural spinal cord compression grading, or Bilski scoring, as it's sometimes known, the grade 2s and the 3s that you can see highlighted in figures B and images B and C down here are where you're actually having compression of the spinal cord with or without residual CSF visible. And in this category of folks, we'd say, unless a tumor is highly radiosensitive, and we'll talk about what radiosensitivity means in subsequent slides, we talk about surgical decompression to try to create a target that is actually amenable to an ablative dose of radiation while sparing the spinal cord an actual toxic dose of radiation. On the other half of this, we have the 0 to 1 Cs, right? So all the way up to epidural spinal cord compression that's abutting but not displacing the spinal cord. Radiation can be considered as initial treatment, but in that 1C range, not all 1Cs are the same, and discussion with the radiation oncologist becomes helpful in terms of what's needed in terms of making space around this. And I'll show a little bit of radiation data that underpins our neurologic kind of assessment of these things. If we switch over to the oncologic portion of the assessment, this is really, I think, the part that's really evolving currently. I'll show some later slides and data about this, but when we think about the oncologic portion of GNOME, it really is asking, what is the responsiveness of a tumor to the currently available treatment? And that includes both systemic treatment options as well as radiation treatment options. We tend to focus on radiation because it's minimally invasive, it's highly effective, and it gives us good durable local tumor control, which we'll talk about in subsequent slides. But it's also historically systemic therapy options have not had good penetration into the epidural space. That is changing, and I'll show some stuff on that later, but this is why we really do focus from the oncologic assessment about radiosensitivity. And so we break this down to kind of three groups of, are you radiosensitive, are you radioresistant, or are you somewhere in between those two? And so on the radiosensitive side, it's the lymphomas, seminomas, myelomas, the hematologic malignancies are the really exquisitely radiosensitive tumors. And it matters because they respond so well even to conventional external beam radiation therapy. Versus the radioresistant pathologies like the renal cells, the hepatocellular carcinomas, the GI tumors, even the non-small cell lung cancer, which is the one that we see a ton of. Like those are the ones that need a higher ablative dose of radiation to get good, durable local control. And then you have things that are in the middle, like breast and prostate, where conventional external beam does actually have penetration and can get good results. Taking into context Saber Comet, PISA trials, things like that, that also show a role for ablative dosing SBRT in the oligometastatic population. But this is really a big workhorse of the GNOME's paradigm of thinking about this, because radiosensitivity really does tell you what you need to do in terms of being able to get control of that actual tumor. And as a great example of this, when we think about those lymphomas and those multiple myelomas that are very exquisitely radiation sensitive, even if we have that kind of grade 2, grade 3 compression, these are people where, because it's so exquisitely radiation sensitive, even in the presence of that high-grade metastatic epidural spinal cord compression, we can consider emergent radiation. And here what we'll do is, when these people come in with an image like you see on the right side of the screen with high-grade epidural spinal cord compression, but either asymptomatic or subtly symptomatic, we'll put them on high-dose steroids, put them into a neuro ICU, serial neurochecks, and give them expedited radiation treatment same day or next morning. And we get those people through it without ever needing a surgery. And so I think that's why it's important to have this understanding of the radiation responsiveness, because it really does impact what your actual surgical treatment should and can be. The M part of the GNOME's paradigm really looks at mechanical stability. And from this end, we use the spinal instability neoplastic score, or the SIN score. And you can see that score tabulated on the right side, and I'll walk through it. But the general nature of this is that lower scores, especially in the 0 to 6 range, are things that are stable, don't require surgical stabilization. Things that are in that 13 to 18 point range are highly unstable and require stabilization to restore that stability and help alleviate the pain associated with it. And the 7 to 12 range is this kind of indeterminate range that needs surgical assessment, or assessment by neurosurgeons to really figure out what do they need, neurosurgeons or orthopedic surgeons, to figure out what they really need. And the higher your SIN score is, the more likely you are to have severe pain. And the reason that mechanical stands on its own is because mechanical stability is something that radiation cannot fix. It cannot improve the pain associated with mechanical instability. And so it sits as its own separate indication for surgery to actually help alleviate and palliate the symptoms of the patient. If we look at the right side and the actual table outlining what all the parts of the SIN score are, it makes intuitive sense, right? If you look at the location segment, things that are junctional, so they're more mobile and have less additional support, like they don't have ribs there, they're not rigid, are going to be more likely to be unstable when there are lesions there, as opposed to when they're in the sacrum or the semi-rigid spine. If a patient has mechanical pain, they're more likely to be mechanically unstable, kind of goes without saying, than someone who has a pain-free lesion or even a biological pain, so a kind of that diurnal variation of pain. And someone who's got a lytic lesion, that's going to be more destructive to the actual underlying bony structure and more likely to be mechanically unstable than someone who has blastic lesion, who is actually depositing bone, like in prostate cancer. And the same thing goes with alignment. Kyphosis or subluxation is going to be more unstable than someone who has normal alignment. And with vertebral body collapse, it's the more that you have of that, right? If you have lost 50% of your vertebral body, the more likely you are to have mechanical instability. And these are all things that kind of intuitively make sense to us as surgeons, but I think it's nice to have a systematized way of looking at it, especially when training people how to look and assess the spine. And so then we get over to the systemic side of things, right? So we've gone through the neurologic, the oncologic, and the metastatic, and those all have their own reasons and indications for doing surgery. But the systemic assessment is actually the thing that can rule someone out, right? If the systemic tries to look at a person's overall medical picture, their age, their Karnofsky score, their comorbidities, what their actual overall picture of their health is, and tries to ask the question of, even if the N, the O, and the M recommend a certain course of action, if we look at them as a whole person, is that the best course of action? And where you see that is in someone who has high-grade epidural spinal cord compression, a radio-resistant tumor, and you'd say this person needs surgery, but you may then say, but they're extremely debilitated, they're highly frail, their life expectancy is maybe 3 months. Should we put them through a surgery or give them a palliative dose of radiation? The systemic actually would tell you, if they're really sick, we shouldn't put them through something that has a 3-month recovery period because they're not going to live long enough to get the benefit out of that. Now, the hard part here is that there's tons and an abundance of data that says that we as physicians over and underestimate the actual survival of patients, and we're terrible at prognosticating this. And to that end, multiple different algorithms have been developed to help us better do this. And to give it one example of this, you can look at the Sorg nomogram, which was validated out of Mass General, and it tried to take in the ECOG status, what your previous systemic therapy was, other comorbidities, your hemoglobin, all these different factors that make up a patient, and then put them all together and then churn out an actual score to say the probability of someone's 90-day and 1-year survival is X. And I'm a firm believer that this score, this percentage, isn't the end-all be-all, but it helps to drive a conversation if you can hang your hat on something and say, to some degree, you have a lower likelihood of being alive at 90 days. Maybe we should do something smaller for you. Versus if someone is 90% chance that they're going to be alive, it shifts how you may view the intervention or option that you choose for them. You may be willing to be slightly more aggressive because there is a longer term survival benefit there. But like anything, it's a tool. It is not the end all be all, and it shouldn't be viewed in a vacuum as a decision-making criteria or something that is an exclusionary criteria in a vacuum. And it's just a part of the actual overall conversation with the patient. Now, so we've gone through the N, the O, the M, and the S, but underlying it all, when we talk about radiation and radiosensitivity as part of the O, we're really intrinsically implying radiation has good control. So I always think it's worth showing the data on what that looks like. When we look at SBRT dosing, what we see in essentially people who are getting just radiation, no surgery, high dose SBRT here. This is a retrospective review from Sloan Kettering, 811 lesions, 657 patients over a 12-year span of time with SRS as a first-line therapy. We were able to get 2-year local control rates of 98%. But when we look at it from the standpoint of separation surgery, so really doing laminectomy, bilateral pediculectomies, reaching around the front and then instrumenting these people, following that with SBRT, we also have data that shows good 2-year local control, even in the radio-resistant histology. So when we look at something like renal cell carcinoma, which if you recall the oncologic slide, was listed out as being one of the more radio-resistant pathologies, we're still seeing 2-year local control rates that are approaching 92% in this group, right? And this is with high dose hypofractionated as well as some single fraction SRS in this group. The majority getting those high dose treatments. If we switch over and we actually look at the same paradigm in non-small cell lung cancer undergoing hybrid therapy, and keep in mind, it's 2012 to 2019, so some of this may even be better with newer agents that are actually popping out and onto the market. What you're seeing here is a 2-year local control rate that almost approaches 95%. And when we look at the actual treatment plans, you see most of these people are getting high dose hypofractionated radiation. So 30 gray and 3 fractions or 24 gray and 3 fractions. Doses along those lines is the bulk of what people are getting here. But if we actually look at colorectal cancer, this is where it starts to get interesting. It's a little bit of a harder to control histology, where we're seeing the 2-year local control rates, even though it is a small retrospective group of just 50 patients over this span of time, having about an 86% rate of local control at the 2-year mark. So not as good as what we're seeing with the renal cells, what we're seeing with the non-small cell lung cancers. And so to this end, I think this gets to the idea of how we actually define that O, or that oncologic portion of the radioresistance. When we start talking about that, we actually did a retrospective review, and this is unpublished data courtesy of one of my radiation oncology partners, Dan Higginson. And what he and his group did is they did a retrospective review of 1,842 patients who were treated to 2,700 lesions with spine SBRT from 2014 to 2023, and then used a recursive partitioning analysis to look at their actual outcomes and figure out, can we use that to classify radiosensitive, intermediate, and radioresistant histologies different than what we were doing in the previous paper that I showed under the oncologic subheader before. And what they saw was actually pretty interesting in that when you look at this radiosensitive category of breast, prostate, and thymic, their 2-year local control rates are about an average of 8.5%. You look at the intermediate category of the non-small cell lung cancers, melanomas, thyroids, renal cell carcinomas, they border around about 13% for their 2-year local control rates. But in this new radioresistant category, which predominantly, if you look at these pathologies, colorectal, esophageal, hepatocellular, pancreatic, cholangiocarcinoma, GI malignancies, there actually are really bad actors. These are the ones where we're seeing, even with SBRT, 20% failure rates or local failure rates at the actual 2-year mark. And I think this goes to say that not all tumors respond to SBRT the same. And so with that in mind, where this is a group of bad behaviors we can truly say are radioresistant, and something that we've actually shifted in our practices where we were starting to treat grade 2 to a lot more upfront SBRT. If you're a grade 2, but you fall into this GI malignancy category, we're really going aggressively after that epidural space to try to get you the best dose possible of treatment, because we know that in this category, it really matters. Whereas in this intermediate category, we're still getting good results of, 13% 2-year local, 13% local failure rates at 2 years, but we'll still be very aggressive in this newly defined radioresistant category. And I alluded to this earlier when I talked about the oncologic segment being really focused on the radiation arm of it in terms of how we define responsive to available treatments. But I think something that we have to pay attention to is the fact that we are getting better systemic options. And so this is a patient who was an EGFR mutated, ALK mutated, PD-L1 mutated lung cancer patient who initially with an unknown diagnosis, we took her to surgery, did a separation surgery. You can see that she had high-grade epidural spinal cord compression at the index level here, but she also had sites of epidural disease that were 1Bs and 1Cs at other levels. We did a separation surgery for her, and you can see here a 2 above, 2 below construct, decompressed her, but we actually didn't treat her with radiation. We put her on a novel agent, and what you can see is at 1 year, we actually had response both in the epidural space and the bony disease at the index level, as well as the levels above and below, which is a game changer, because historically you would think of epidural disease as something that required radiation treatment, but there is emerging data that there is penetrance into the epidural space with some of these novel agents. But the caution here is that we don't know who is going to respond, who is going to have a quick response versus a durable long-term response. And if you look just 3 months later, this patient had progression of their disease and wound up getting radiation to the areas that we hadn't treated before. So this is not to say that we're in an era yet where we can hang our hats on systemic therapies as having epidural penetration and being the workhorse where radiation has been for all this time, but it's saying the field is shifting, the field is evolving of kind of medical oncology, and we have to pay attention, because at some point we may be using certain agents in combination with surgery or even before surgery to actually treat patients. But this is kind of emerging stuff, but I think it's worth noting and highlighting. And so if we try to summarize all that information of how do we think about gnomes and how does that work? And I love this slide from my partner, Mark Bilski. And it's really saying, look, in people who have a radiosensitive tumor, but either high grade or low grade epidural spinal cord compression with or without myelopathy, get them the conventional external beam if you can. If you can get it done expeditiously, this is what we tend to do. If you don't have that option, you do surgery, you get them out of trouble, you keep the patient safe. But if you're resourced enough and you can get them to expeditious conventional radiation, it will melt away, it will get better, as we talked about earlier. In people who have radio-resistant tumors with low-grade epidural spinal cord compression, so those 0s, 1As, 1Bs, and some of the 1Cs, we'll take them straight to SBRT because we know that an ablative dose for most of those pathologies will work well. And that's the data that we showed. In the group where they have high-grade epidural spinal cord compression with or without myelopathy and a radio-resistant pathology, or they've been previously irradiated, right? So re-irradiation is needed. We talked about the failure rates. We will take them to separation surgery, and then we'll take them to either SBRT or stereotactic radiosurgery, depending on what the actual imaging looks like post. And then mechanical instability is its own separate indication, right? So if you're mechanically unstable, stabilization surgery makes sense. You do it, you actually alleviate the pain, and that's something I think we've all experienced and have seen. And then the systemic part of this, right? If they're able to tolerate surgery, you take them to separation surgery, and then you can take them to their radiation afterwards. But if they can't tolerate the surgery, they can't tolerate your proposed intervention, you got to think about getting them to radiation to palliate their symptoms, because putting someone through a large surgery that they're not going to have time to recover from isn't doing them any favors, when the goal of much of what we're doing surgically is palliation or getting them onto a definitive therapy. And so if I can do a quick case presentation just to show what this looks like in action, this would be a 57-year-old woman with metastatic leiomyosarcoma, new spine metastases, so kind of first presentation of spine mets. Neurologically, she's myelopathic, but she's full strength. You can see that she's got high-grade epidural spinal cord compression on the axial images, the T2 and on the T1 post-contrasted. From an oncologic standpoint, leiomyosarcoma is radio-resistant, so we know it's not going to be one of those where we can take it on to conventional external beam and try to treat it like if this was a myeloma or something along those lines. From a mechanical standpoint, no mechanical pain. And from a systemic standpoint, she's relatively healthy. The KPS is 90. Disease has been controlled other than this new metastasis, and she's been controlled for about a year. And so this is someone where we would say, look, this is someone who needs a separation surgery to create a target for definitive radiation or an ablative dose of radiation. So we would take her to the operating room. And here we've been doing a lot more short segment surgery. So we do a screw above, so T8 to T10 separation surgery. So rods and screws drilling out the pedicles bilaterally, as well as a laminectomy. You can see what that looks like on the postoperative lateral x-ray, but you can also see we get a lot of postoperative myelograms. You get reconstitution of the fecal sac in the actual area, accounting for a little bit of postoperative hematoma that can always be in the actual cavity. And intraoperatively, we always get an intraoperative ultrasound and look, and you can see the quality of your decompression, where here what you can see is spinal cord in the middle with the red asterisk around it, but then fecal sac here with the CSF and full pulsations there. And on a lateral view, you can see just how free that cord is now compared to what it was before. And I always think it's worth saying and highlighting that when we talk about separation surgery, it's not just a laminectomy. It really is laminectomy plus drilling the bilateral pedicle to be able to reach into the ventral epidural space, cut the PLL, access the ventral tumor, and really do a thorough decompression, including sometimes taking a little bit of the vertebral body out to actually get the good decompression. And when we look at what that looks like, 2 years later, she's doing well, absent perfusion at the index level, has good disease control. And so I think this is how we think about this fitting into this paradigm of really taking the N, the O, the M, and the S and factoring it into how we treat the patient. So with the last slide, what I'll say is just a couple of conclusions. That the use of these decision-making frameworks really helps to systematize decision-making in spine oncology. And it doesn't matter which of these decision-making frameworks you're using. Like, we love gnomes, we think it's the best, but there are lots of options around. And as long as that framework gives you the flexibility to account for new therapies, novel things in the way the medical oncology field is evolving, it's going to work for you. Just have a way of formalizing your thinking. Help all of us. The area of SBRT spine mets in their local control is still histology dependent, right? The GI cancers act worse than some of the other ones, and it's just something that we have to be aware of. Patient prognostication tools are adjuncts, but they're not the ultimate decision maker. It really is a conversation, and it's the art of medicine. And as we get more and more novel systemic therapies, they're going to change what our indications look like, both for operative indications and our radiation indications. And I think that's where things are heading. So with that, I will stop and I'll say thank you for your time.
Very good. Congratulations for your beautiful presentation. I think that it was a great, huge overview of all up to date in order to manage this challenging topic. I've enjoyed so much all your options for a complete treatment, but I didn't see any reference to embolization. What do you think about embolization, both on the pain killing and surgical decompression and oncologic reduction profile?
Yeah, so I mean, I think that's a great question. And actually, I have some data that's unpublished currently that's going to be coming out hopefully in the next few months. So if I think about last summer, the summer before, there was some data out of the Ohio State University group looking at whether or not preoperative embolization of tumors leads to better local control, better kind of overall survival. And they showed some benefit in that. We've done our own series where we looked at it a little bit more homogeneously because they have kind of an all-comers look of breast, prostates, lungs, kind of a mix of radiosensitive and radioresistant histologies in there. And for us, we've really traditionally used preoperative embolization, not for palliation of pain, but really when we think about pre-surgically going after reduction of blood loss and really looking at tumors like hepatocellular carcinoma, renal cell carcinoma, and some of the thyroids, like medullary thyroid, which tends to bleed a little bit much. And we really use it for kind of blood loss control. So we actually looked at our data, and we have a series of about 130 to 140 patients who over the same period of time either did or did not get preoperative embolization for those three histologies. And what we see is that we don't see any overall survival benefit. We do see a reduction in the actual amount of estimated blood loss during surgery. We don't see survival benefit, and we don't see local control benefit, which to some degree makes sense because if you're embolizing a tumor, you may actually be decreasing blood flow, which then actually may have some implications for how the tumor responds to radiation therapy, but also you wouldn't intrinsically think that it would have an impact on overall survival as well. So what I'd say is, for us, we think about preoperative embolization from the standpoint of helping us with decreasing the blood loss in a patient who's already, got a lot going on from their cancer diagnosis standpoint. We don't lean on it as much from a pain palliation standpoint. We'll use more kyphoplasty. We'll use more radiation surgery to try to get control of the actual oncologic portion of that with, I think, good results. But we really use the embolization as a preoperative workhorse for those vascular tumors.
Thank you.
Yeah, can I ask a question? Yeah, means when one follows the NOMS protocol, how do you decide the survival? Means it has been difficult to decide because the whole decision to treat or not depends on the survival of the patient.
Yeah.
So what do you follow? What protocol you follow to decide the survival?
So I know that I put it out there as a, plug it into the nomogram, see what comes out. But I think really what we lean on is this multidisciplinary conversation where we sometimes will use nomograms to help inform us. If we look at someone, like they look really sick and medically we feel like they're sick, but the oncologist is saying, I think that they've got a, good long-term, we'll use the nomogram to help inform our actual conversation. But I think a lot of it really does boil down to having these talks with our medical oncologist about what the options are. And so I had a woman the other day who, if you plug her into one of these nomograms, it'll tell you 10% of likely survival. And she's running out of options X, Y, and Z, but she's high grade compression, grade 3, and like becoming slightly myelopathic. And even the oncologist say like, yeah, she doesn't have good options. But then part of the conversation around survival is we've got this new targeted, CAR T cell therapy that if we try it, 10% chance she's totally cured and it's all done, versus 90% chance that that doesn't work and then she goes on to die from it. So I think even with nomograms and other things, it's a conversation with the medical oncologist about what options do you have? What does that look like? And when we think about the way that we do our surgery, we've gone to doing these shorter segment surgeries because when you can keep the blood loss under 300 milliliters and when you can get them in and out of surgery in 2.5 hours, they tolerate it well enough to where it seems like it's an okay risk to take for them. But it's a conversation with the medical oncologist who really have known them throughout their entire cancer diagnosis, really understand what their options are. And then we bring in the radiation oncologist because sometimes we'll say, yeah, it's a grade 2, but it's a kind of grade 2 where we can hit it with an ablative dose, and that's the best option for them to keep them on therapy. So there's not really a great answer, but it's this multidisciplinary conversation that lets us try to be as good as we can about it until we start using AI better to really understand all the different risk factors that are in the patient's chart.
Yeah, thank you, Professor Newman. And I think because